Have you ever done a podcast before?
Never done a podcast.
Okay, well, the way we do it, there's not really a rhyme or a reason.
All right.
No script.
Yeah.
Fair enough.
So basically, welcome to another episode of the American Iron Podcast. Today we have Dr. Jones. Actually, do you want to just introduce yourself? Talk a little bit about what you do?
Sure. The name is Jackson Jones, orthopedic surgeon. I specialize in hip and knee replacements. So basically when the joints are worn out, you've got arthritis and you have to bypass the arthritis. We're not doing much in the way of repairs. We're just replacing the joint. Training-wise, I did med school in Washington, D.C., George Washington. Went on to residency in Oregon Health Sciences, and that's where you get all general orthopedics. And then I did my fellowship at Harvard. And the fellowship is specialized training with hip and knee replacements. Did a year of research in stem cells.
I have a lot of questions about your stem cells.
Okay, fair enough.
But a little bit more, you have a twin.
I have a twin brother.
And he also went to med school with you?
He was at Columbia Med School. He decided was doing a year of research. He was going to become a neurosurgeon. And during his year of research at Columbia, between the third and fourth year, they had a real focus into the specialties. Columbia did. And so they were encouraged to do a year of research in between their third and fourth year of med school. And he was in his year of research for neurosurgery, and then decided that he didn't like that very much. And he was inspired by some friends I had that were in the banking world, and so he ended up getting his MD MBA from Columbia, and then just walked out into investing in the healthcare space. And has had some iteration of that for a while, and now he's over healthcare for the World Economic Forum.
Pretty impressive.
Yeah.
Yeah. So you two travel a lot.
Fair amount.
And I think a lot of your practice is working on athletes.
In no small part thanks to you.
Yeah, well, we have a lot of opportunity to
Yes.
to refer. But you're an athlete yourself.
Yeah.
Pretty amazing athlete. As a matter of fact, I had a video from you or a text from you last year that scared the shit out of me.
Mm-hmm.
Was your brother videoing that?
He didn't see it.
He didn't see it.
He was going to be the next one down the slope, but it was a blind hill. I assume you're talking about the avalanche.
That's what I'm talking about.
And so he didn't know the way that it worked in Alaska. I was up heli skiing, and they had the guide go down first if there was any high risk terrain. And we started at kind of a low slope, but then it ended up going into a blind slope after that, which was steep enough to be at high risk. So the guide went first. I went next. And you couldn't see the guide. We were on radio, so they're telling you just stay in my tracks and head down. And then when it was my turn, I got caught in an avalanche. And then the entire group, including my brother, sat up there for 45 minutes until a helicopter arrived and picked him up and said, "You're not skiing that slope.
No.
It's already avalanched."
Yeah. Did your brother know that you were okay? Was
not until the helicopter landed to pick him up and said, "Hey, FYI, your brother was in an avalanche, and he's fine now." So, yeah.
So you do some pretty extreme shit. You do. I mean, between your surfing, your skiing, and you're an orthopedic surgeon.
Yeah.
So you know kind of what can happen to the body and.
A lot of orthopedic surgeons were former athletes, and I was always a fun athlete, but there were a fair number of pro athletes that then go on into med school and orthopedics. So it's we all kind of gravitate to that field with a history of athletics.
Why do you guys think you guys take that kind of route?
to some degree, athletic injuries, a lot of people that when they pick a specialty were related to that specialty or could relate to that specialty somehow. So, for instance, all psychiatrists are insane, and so they gravitate towards psychiatry.
Keep that in.
People have had some kind of an injury. You talk to people who have had a cardiac issue when they were young, so they end up becoming cardiothoracic surgeons. Things along those lines. I knew a dwarf that went into general surgery, and he had a lot of issues with his dwarfism as a child, and he ended up going into pediatric surgery. And all athletes get injured, and so we end up sort of gravitating to what we knew. So I think that's probably the gist of that.
It seems from the outside, knowing a few orthopedic surgeons from personal experience, that you tend to have that warrior gene. A lot of you do. You're more, you're just more athletic. You're more athletic people. You're more aggressive. And I don't mean aggressive in personality, but aggressive in how you approach things. Is that?
That's definitely a fair assessment. You don't. There's a get it done approach. We like that immediate feedback of success. We don't like the slow roll. We don't like the take this medication. We'll see you in 4 months and tinker with this a little bit. We like to see a problem, fix it, and move on, which I think does correlate with sports to some degree.
Yeah, and the personality that's attracted to that for sure. Interesting. All right.
I guess that does kind of explain Jeremy a little bit. Because you were talking about Jeremy before we started this.
Yeah.
And like his eye for things. I'm curious how you approach that.
So Jeremy, I'll give a little bit of his history, which I think has led him to have that eye. He's self-trained, obviously. Yeah. But he talked about several years where he changed everything. He was going for the lifting, but then decided to change and analyze every movement. And then him and Jesse would literally he was telling me the story that every single rep they would analyze. They would say, someone would do a set and they'd go, well, it didn't seem like that was moving. That's moving. You're recruiting the hamstring. You're not recruiting the hamstring. But they did that with every exercise they had, and they did it all day, every day for 9 years. And so I think he trained his brain to just see things in that light.
I spent quite a bit of time with Bob, too, and Bob has the most incredible eye in being able to watch someone and go, okay, this part of your tricep movement is weak.
Yeah.
So these are the exercises we need to do, to make a difference in that.
Yeah.
I mean, Bob took he was coaching the U.S. team, and we loved him because he's just such a calm influence when you have PMS, pre-meet syndrome, right? And he took one of our lighter weight girls she'd never medaled at a world championship. She'd been on the team for 3 years, and she sumo lifted, or deadlift with sumo, not conventional. And he said, do you trust me? She was on her last deadlift, ready to bomb out of the meet. And if she made that deadlift, she'd get a silver medal. So there was a lot at stake. And she was like, I absolutely trust you. And he goes, okay, we're going to go in the back, and I just want you to do 1 rep in a conventional style. Because he knew that she would have been a much better conventional lifter. She trusted him enough to do that, went out and pulled her third deadlift effortlessly, did not bomb out, and took a silver medal.
Oh, wow.
It was pretty cool. That's pretty amazing. So I think Bob and Jeremy share that similar eye to be able to really know what's going on under the obvious,
Yeah.
It's pretty cool.
It's fun to see it because I sure can't see it.
Yeah. It's great to watch Jeremy work with your patients because everyone is different, right? And some of them, for whatever reason, never had glute engagement, or they couldn't activate their VMOs prior to the surgery, and all of that's going to affect their ability to recover. So his ability to see that and focus on that and make the person better. You created a foundation that now they can improve and they can change, and it makes a difference in their quality of life, right?
Yeah.
So it's pretty neat to watch that happen.
Yeah. It's been a nice resource because I think physical therapy, that was their job, and they've given up on that. And that's been a huge issue of mine, specific to my profession, where they don't strengthen anymore, and that deficit needs to be filled in somewhere. And a lot of people are left floundering. A lot of people are left injured because a lot of therapists have given up that analysis. I remember going to a conference early in residency, a sports conference, and this guy was going into shoulder dynamics, one of the physical therapists, and the 17 muscles that attach into the scapula. And so needless to say, there's a little bit going on there with, it doesn't take much to mess up the movement of the scapula. And there was heavy analysis into exercises and things along those lines to get your shoulder dynamics working normally. And that's what therapy used to be, was doing that. And they don't do that anymore.
You're right.
So
I got to experience that with my hip and my knee. By the way, Jackson, Dr. Jones, I have him on speed dial.
I feel like half this gym is on.
And they
keeps you on retainer.
I replaced my hip and my knee. Phenomenal. Definitely gave me my life that I'd like to live back. So thank you so much. I've seen him do it over and over and over again. And thank you for trusting us, because it's without the rehab, the training, the actual strengthening, I don't know if we'd have that same outcome.
Our association has completely changed the way that I think about recovery. We used to do the surgery, hand everything off to the therapist, and then look the other way. And we'd have people come in, and there was this statistic that we all quoted, the 7% of knee replacements have severe pain afterwards. And we were looking at it in terms of there's something we must have done wrong with the surgery. And so we've always been chasing our tails with what do we need to change in the surgery, what was missed. And there would be this contingent of patients that just never got better. Fair number of patients, especially probably more and more as therapies continue to drop the ball, that they come in saying, it hurts when I go up and down stairs, it hurts when I try and hike, I can walk fine, but the rest of it, I'm still limited. And it was sort of our association that really started to get me to focus in on that final phase of recovery. I think it's especially started with Adrian.
Yes, it did, yeah.
And then sort of you took over Adrian's recovery and worked miracles on her, and it sort of took off from there. I guess briefly, Adrian was a pro downhill mountain biker, but obviously did a fair amount of biking where she was going uphill too. And then I've skied with professional skiers, and I'd put her right on the level with any of the top skiers I've ever seen. Definitely among females, probably you could put her into a tiny room with a collection of women that could ski at her level in the world. And she had no quads, no hamstrings, severe knee pain. She was getting cortisone shots every 2 weeks. And then we started to really see how the quads and the hamstrings shut down with arthritis. At the age of 40, she had severe end-stage arthritis, and when you got a hold of her, she started getting quads for the first time in 10 years. They've been gone for 10 years. And her pain went away.
Yeah. That was wonderful to see, because you see the joy in the athlete. As an athlete, you see that in another athlete, and you go, yeah, you don't have to live that way. We can fix this.
Yeah.
You know?
And
it's pretty cool.
I'll tell you what, you go to conferences, and it still isn't really covered right now in the world of orthopedics, because, again, we handed the baton off to people who are just not running with it, with the therapists. We're starting, you've kind of opened my eyes to that final phase where you get your strength back, and it's just they drop the ball all the time, and we're starting to see people just are not getting their quad and their hamstring strength back. They're not getting their hip strength back.
Well, because no one's giving them, teaching them how. You have to re-educate your body on how to activate certain things. When you're injured, especially like your VMO, it shuts off.
Yeah.
You know, you just don't get that quad activation, and you have to do specific movements to force your body to utilize that and re-engage it.
It's been a game changer in my practice. All of the people that came in and saying I'm still having pain, I immediately looked to the thigh. The thigh is almost universally atrophied. It hasn't come back even in spite of the surgery, and then if I can get them to either go to their own gym, do exercises on their own, ideally heading off to your gym, they all come back feeling better.
Absolutely. And they could even do it at home, but it's really hard if you don't know how to activate something. It's hard to just do that, right? You need someone to kind of help you a little bit, do the proper exercises to get that activation for sure. And glutes too. You probably see a lot of glutes that are totally not activated.
Yeah.
So lots of hip pain, and we talked about that with the hip surgery. Why so many people have that anterior pain, right? Or it was
psoas tendonitis. Yeah.
Okay, and it was because there's no glute activation, so that whole complex works. It doesn't work correctly.
Yeah, which again is counter. You send people to therapy for psoas tendonitis, and what therapists do now is just stretch people and massage people, and they don't do the exercise. But if you will get them to do exercise, they start exercising the psoas and completely neglect the glute. So it's actually making it worse.
Exactly.
So at this point, I try and encourage them to get outside of the therapy, and because they're going to exercise the wrong muscle.
Right.
And they're exercising the wrong muscle because they're not thinking exercise anymore. So they don't know what to do.
Yeah, it's sad because there's so much out there.
Yeah.
Well, and the tools too that we've used in the athletic, environment forever, like the compression sleeves, right?
Mm-hmm.
I remember the first time we used that on one of your patients to get the edema out of the knee and leg, and that's a game changer. Because all of a sudden then they can get a full rotation on a bike because there isn't all that edema in there. It's inhibiting that movement.
I mean, what would take 2 weeks of elevation and icing in 10 minutes, happens with a compression sleeve.
Yeah.
Yeah.
Yeah. It's crazy that's not part of every orthopedic surgeon's protocol.
Yeah.
Why not?
Well, we don't have protocols. That's the issue. We hand it off to quote unquote experts, and this isn't to bag on all the therapists out there. There's some great therapists, but I have a theory about what's happened, and I think as therapists have started to develop more independent practices away from hospitals, away from hospital groups, they've found that they want to do things that make patients feel good. And if you've got someone who's never exercised and you bring them in and you stretch them and stretching feels good, and you massage them and massaging feels good, they come back. But if you get in there and you say, hey, I need you to exercise, and you got to exercise harder, and you're not activating this, so we're going to really push into this, people will go, wait a minute, that hurts, and this takes effort. And I heard the guy down the street is just going to give me a massage and stretch me. And, even the best intentioned therapist who owns their own practice starts to see all their patients go away. To the guy who feels better, you start to watch the whole practice start to trend away from the exercise because that hurts and towards the things that feel good.
Yeah.
That makes a lot of sense. people want that quick relief versus the long-term actual benefits, and so they think, oh, this hurts, this must not be working, versus, this feels good in the moment, and it's like, no, it's like cocaine.
Yeah. Well, we know pain is gain, right? As
Yeah.
athletes, we know pain is gain.
100%.
And so our approach is going to be make it hurt more
Yeah.
because I want to get better.
And you try and tell, a 70-year-old person who's never really exercised, that's worn out their knee, pain is gain, and they
Like
they hit
hell
the
it
highway.
is.
Yeah.
That's interesting because we know a particular physical therapy group that used to be really hands-on and focused on exercise. When I had my knee, I went to that group because they were referred, and they never touched me.
Yeah.
I'm like, how can you know where I'm at and what I'm doing if you never put hands on me?
So the other reality behind this, and this is a reality for all of medicine, on top of that, the fact that they're just kind of putting you through the runner, but I'm guessing there were several other patients that they were running in between at the time.
Absolutely.
And what we've seen is, Medicare, medicine's the only profession where compensation goes down every year rather than raises happen every year. And as they've done that, they try and fill in the gap with volume. And then you lose that personalized touch as they're trying to treat 7 patients at the same time rather than 1.
Yeah, there was never less than probably 7 or 8 patients in the room at the same time.
Oh.
And so they put you on a machine that, the ice machine, right?
Yeah.
But there's very little actual physical therapy touching you or seeing you. It's the aid that implements some of their modalities.
Yeah. Just gives you the schedule and says, I'll be back in 10 minutes.
Uh-huh.
Yeah. Exactly.
Yeah, it's frustrating. So yeah. So what we were talking earlier, and I wanted to talk about it on the podcast, about squats and someone who's had a knee replacement, and you were asking about the change in the squat because the range is different. So tell me, educate me about that.
So with the one of the things, I guess, with your gym and the patients that come from your gym is now we're diving into activities that really weren't encouraged or even discouraged from total joint patients. And so this is all new. Having a knee replacement go in and start to compete in powerlifting is just unheard of. I was back with my mentor at Harvard, and the recommendation he always gave was no more than body weight lifting. and a lot of that was some was based off old materials, but some of it was also based off of just better safe than sorry, and the expectations of what was possible wasn't really there. So this is all somewhat frontier stuff in terms of what does this mean now. So with a knee replacement, the way that it works is we're resurfacing the bone, and right sitting smack dab in the middle of the tibia is your ACL. So that just goes with a knee replacement. I was doing for a while ACL sparing knee replacements. That had its own set of problems, which has sort of led me away from it. But what I was doing at the same time was I was analyzing knees with ACLs, and is the ACL viable? And if the ACL is viable, I'll use it. And I look back on my cases, and about 38% of ACLs were viable by the time they got to me. So that means the majority of people are running around without a viable ACL. But they have done studies that have shown that recovery is different if you take the ACL versus if you don't. And what the ACL does is it keeps the tibia, the shin bone, from translating in front of the femur.
Okay.
And so what happens after you take that is all of a sudden the hamstrings become much more important, because the hamstrings are going to pull that tibia back underneath the femur with the way they attach. And so getting that strength back up is going to be a chore and vital to making your knee dynamics work.
That's the reason there's so many ACL tears, because of a weak hamstring.
Which is interesting because the popular graft for a hamstring or for an ACL is the hamstring. So they'll harvest your own hamstring on the same knee.
That is true. They did that for Jared.
Yeah.
Yeah. And then I remember talking to more elite athletes, and they say they could tell a difference in their hamstring strength. Like they always lost a little bit of a step in their strength of the hamstring with that. We use the hamstring because it's the studies showed that it's stronger than other grafts that we can use. There were big issues doing a piece where you take out a piece of the bone from the kneecap and part of the patellar tendon and then a piece of bone from the tibia and use that as your ACL. That was strong, but then you couldn't kneel afterwards. When that went bad, it could go really bad with bones, your patella exploding, things along those lines because you created stress riser.
Yeah.
And so they wanted more of a soft tissue option, and hamstrings are nice and strong, and so they use that, but they're taking the thing that protects your ACL to replace your ACL.
Right.
And that's not good.
Yeah. That's wow. Yeah. Yeah. And that's why, but that's, I mean, weak hamstrings is why we see so many injuries in female athletes, young female athletes, you know, and especially if they don't have a good trainer and they don't have a good coach that really focuses on strengthening that, because they're inherently weaker anyway.
Yeah.
So.
The interesting thing that we were talking about related to squats is that your ACL creates rotation in the knee, 14 to 17 degrees, looking at anatomic studies. And they've done similar studies when your ACL is gone. It now turns into a true hinge. And there's only 1 to 4 degrees of rotation, averaging about 2.
Okay, so not just an ACL that's gone, not
so
even
you take
a replacement.
the ACL,
you take it out.
You take out your ACL, and you now have a hinge knee, a true hinge with no rotation. So, question is, does that incur an advantage in your squats? Is it obviously it's going to change your form somehow, or does it?
I don't think it does.
So
No,
complete.
because
So
it's
the
a pretty-
rotation as you're going up into a standing, and it's the rotation of the tibia relative to the femur.
I think so. Maybe in extreme wide squatters, it would be a factor. But right? Wouldn't you think,
That's
Brandon?
what I'm thinking.
Maybe geared lifters, when they wear gear suits, because they tend to be able to squat wider, and that's actually where they get more out of the suit. I think that there may be some effect there, but I don't.
Because it's way more hinging.
Hinging, yeah. I don't think I feel any rotation in that when I'm squatting. So that's an interesting question. I'm going to have to.
The reason I brought it up is that the world's biggest squat was a guy who got 2 total knees.
Yeah.
Russian guy.
The Russian guy, yeah.
So did he come back with an advantage because now he was rolling with a hinge versus something that was rotating?
You know, I'm going to have to look at his video and see where his position is, right? And like I said, I mean, squats are so where you need to be, where your foot position needs to be. It's so individual, you know, femur length versus tibia length versus your upper body length, and how
feet out,
feet out,
straight.
how where your hip is, how your hips are built. So it's all so unique to each person.
Yeah.
That's what drives me nuts about coaches that say, this is the way you have to squat. And everyone gets, that templated, this is the way you need to squat. No!
That's so annoying.
It is. It's
'Cause
like...
then they get stuck into like a really bad habit.
Mm-hmm. That's totally wrong for them.
And then
right?
you try to change it to something that's actually what they're supposed to be doing. They're like, this feels weird.
Yeah.
Well, it's like, you've been training all the wrong spots for so long. You're going to end up needing a hip replacement.
Like the young lady that saw you today.
Yes.
World-class athlete, definitely. world-class powerlifter, amazing, but definitely she's tiny, and maybe the weight.
I mean, the question is, a lot of people wear their joints out. They start the process of wearing it out 20, 30 years before that finally wears out.
Yep.
That injury that happened 30 years ago, early on, teenage years, 20s, finally gets you through the cartilage, and then you've got a worn out joint. So the question is, powerlifting, did she tear up her labrum? Did she do things like that when she was younger?
She's a gymnast.
Never mind about the powerlifting.
So
Gymnasts will do it.
I think, talking to her, I think that the gymnastics actually probably
tore it up. Yeah, say no more than gymnasts. You end up tearing a lot of the soft tissue support for your joint.
Mm-hmm.
So we see a lot of gymnasts come back with joints like that in their 40s.
All right, that would make sense more than because obviously I know a lot of powerlifters, and there's not percentage-wise, there isn't a large percentage that's having hip and knee replacements, right?
Yeah.
So.
You think you were windsurfing?
No, that was the quad detachment, the windsurfing. that was the other way.
Windsurfing when you were younger. That led to the
or the motorcycle, or the rock climbing and falling, or the skiing off cliffs. It's the landings.
It's always
Jackson,
the landings. It's not the launch.
Right? Yeah. So those damn landings, man, they got me every time.
Yeah, I fair enough. Probably 6 or 7 things.
Yeah, all contributing to the end effect.
Yes.
Yeah. So, but one of the questions, to go back what you were stating earlier, is not really knowing what the limitations of these are in the powerlifting world.
Yeah.
Right, knees or hips. My question to you with the knee was, how much can I deadlift now? How much will this thing, allow me to deadlift? What's that breaking point? You were like, well, we don't know, Tammy. We'll just have to watch and see.
The answer is you tell me.
Yeah. Well, and I got up to, and it wasn't a lot of weight, but for my body weight and the size, I think, of the joint that you had to put in, I did at 450 after that, and it seemed to be fine.
Yeah.
So we know it can handle that much, right?
Yeah.
I'm no Travis Ortmeyer. He's going to definitely put the stress test on that.
We'll see where it's at.
He's already been putting some of the stress test on it.
Yeah. He's, 7,800 now?
Yeah.
Back to 7,800 on his stats.
I know, at least on the eccentric for sure.
Yeah.
And off of blocks.
Yeah.
So he's been pushing the eccentric really hard. And he seems to like it, especially with the hip.
Yeah, he's a pretty amazing athlete, though.
Yeah.
It's hard to equate what he's going to be able to do to anyone else, but it will test the structure of the
It'll set the limit. I think he will officially set the limit, I'd imagine.
Yeah.
So that's again, I went back to that. I was hanging out with my mentor. He did a lot of materials studies back at Harvard, and was looking at the polyethylene, a lot of the bearing surface stuff, and I asked him, should I be counseling him differently? And he goes, we don't know.
Yeah.
We really don't know. So he was curious to see how far he pushes it.
And the other factor is going to be someone like Travis, or most of the athletes in here, they have a lot of muscle around that replacement, right?
Yeah.
They prehabbed coming into it because they were already training, and then they did extensive rehab afterwards.
Yeah.
So they have a lot of support structure around it.
Mm-hmm.
And it's just a theory. You tell me if it makes sense or not. But I would think that someone who didn't have that support structure and that muscle, there might be more stress and damage to the prosthesis itself, right?
Yes. Yeah, because you have 2 things that you can rely on when you're active. You can rely on the static structures, or you can rely on the dynamic structures. And the less you have of the muscles, the more you're going to rely on the bone, the implant, the ligaments. And we see that a fair amount with the prehab that you're doing, where when when you strengthen the quad and the hamstrings on these people, then their bones hurt less. And so the exact correlation with that is that means the bone's feeling less stress.
So working, because I know you work with general populace as well as athletes. What's the difference when you're going in and doing surgery on one of the athletes, strength athletes versus a normal populace?
Mm-hmm.
Is there things that you have to do differently in the surgery?
Exposure's harder in hips. It's a lot harder. So with the hips, we got to get the muscles out of the way. And so the stronger the athlete, the harder it is to get the muscles out of the way.
I just keep thinking about Travis.
He actually wasn't bad.
Really?
He's super flexible.
I'm going to tell him he's weak then.
Yeah, I told you I had fingerprint bruise marks on my throat from someone grabbing my leg during the surgery.
It wasn't fingers. Or
The clamps?
Yes.
Okay, nice, thanks.
No, it's the flexibility helps quite a bit.
Yeah.
And someone like Travis was not as bad as others have been because he was flexible.
Yeah.
He was tall, which helps stretch out the muscles and allows me to move things out of the way. My worst surgeries in terms of getting exposure are short, thick, muscular men, and thick, muscular women who don't stretch. It's hard to get that muscle out of the way. Yes. But those are the hardest, and they're the most painful after surgery because you got to pull on the muscle.
Yeah.
The ones that come out of surgery with no pain are generally older ladies that don't have much muscle tone. They pop right out of the hip surgeries with no pain. Knees are different, way more reliant on muscle tone to feel better. And so the pain in a lot of people won't get better, and that's going up and down stairs, down steep slopes, things along those lines until they get the muscle tone back. Yeah. But that immediate post-operative pain where they're feeling the stretch of the muscle, it's a little bit worse in athletes.
Yeah, makes sense.
Harder bone.
How much force are you really using on like the thicker athletes to really move stuff around?
With the instruments, the table, the positioning, it's not that bad. With the force, we just have to work. Generally, you're going deeper into the wound because the muscle's thicker, and it's the hard part is getting the hip to come out into the area where you can work on it. Because everything's tight. So we're not necessarily pulling harder, although we do pull a little bit harder. We have to release a little bit more, so there's a little bit more that's going to have to heal afterwards to get it to move out into a space where we can work on it. Probably the hardest thing for me is thick bone. You have to broach out the inside of the bone. So like in a young man, the marrow is extremely dense, the bone is thick, and so that can be an exhausting day if I've got a lineup of athletic men with thick bone where they've been, especially activities that have a little bit more of a pounding to them. The best example, the hardest bone, the thickest bone, the most narrow canal that really, really kicked my butt was a ski jumper.
Makes sense.
Olympic ski jumper. He had virtually no canal. We put a tiny prosthesis in there because we only have the fit of the canal, and it was hard getting what bone he had in there out.
How was the outcome of that?
He was fine. Yeah. You don't notice the thickness of the metal. Okay. But it was, he was shorter, extremely thick thighs, hard bone. He was just this perfect constellation of everything that makes it tough. Yeah. That was a rough one. But, outcome was good. He was a lot more sore for a lot longer than most people.
But he's recovering. He's back to jumping.
You always get back to normal.
Yeah.
Yeah. But
awesome.
it's just a longer recovery.
Yeah.
Yep.
Yeah. Interesting. So when someone doesn't train,
Mm-hmm.
What's the typical recovery?
Variable.
Okay.
Highly, highly variable. And I think that's why we haven't focused on this, is because there are people out there that you can do the surgery. They go through therapy that wasn't that effective. It just got their range of motion back, and then they feel great, and they never have a problem. There's enough people like that regardless of what happens, are going to feel better, that we haven't really focused in on where the problem is. Generally speaking, recoveries take longer for more athletic people.
Yeah.
Because they're demanding more. So they notice a lot more. The weekend warrior that's, their big day is Costco, they feel like they're back to normal quite a bit sooner, but they're not really stressing their body.
Right.
Versus, the judge, when he did his knee, he said he felt changes up to a year and a half afterwards.
Yeah.
Even though he was competing at 8 months, he felt changes for that long. So the perceived recovery is longer for athletic people, just because they're going to demand more, and so it'll feel longer to get back to normal.
Yeah.
And then there's a subset of the population that we've really focused on, that I've sent to American Iron to get better, that 10% of patients that just never get their strength back, and they'll feel pain up to a year out. They might feel pain up to 3 years out because they just haven't gotten the tone back. And those are the people that are going to do much better if they are exercising right from the get-go. Because we've taken them 3 years out from a knee replacement. They come in, they say, I have struggle going up and down stairs, I struggle with slopes, and within 2 months they feel better.
They're fine. Yeah.
And they've been suffering for years.
So that leads me to another question. One of the things you mentioned was that because of the injury, I had stretched out the MCL, and you were worried about a brace. The theory, or wives' tale, I guess, that you hear is that once you stretch something out, it doesn't ever come back. You can't.
There's if you strengthen the muscles around it, then that isn't necessarily the case. So if you can get if you don't have strong muscles and you're relying on the static structures, it's not going to go in the other direction. It's not going to get tighter.
So you're calling the MCL a static structure then?
Fairly.
So
static,
even if it is stretched out, it's still probably stretched out.
Stretched a bit, but you're compensating for that with the muscle tone around that. Yeah.
Because so that's another good reason to do strengthening, because it's totally stable.
Yeah. Now. That's going to be muscle, and if you're not putting tension on it, it'll probably tighten up to some degree over time.
Okay.
If you're keeping everything, because ligaments and capsule, we see this when people have arthritis and then they're not stretching it out all the way, that they'll tighten up over time.
Yeah. And
they'll tighten because there hasn't been any tension on them, and they end up matting down and tightening. And we'll see people that, like a varus deformity of the knee, and that's where they're bow-legged. So it's shortening the MCL because they're not really putting stress on their MCL. They're collapsing the inside of their knee, and so that length of the MCL is shortening. And then when we clear everything out and take away the arthritis and take away the bone that's causing the problems, it's still shorter. So it tightened over time. No one really talks about that, but over time, if you can protect it for a long period of time, I think you will see some tightening of it.
Interesting. Okay.
Again, that's not in the textbooks, but it's just you don't see a lot of people actually protecting it like that.
Right. So that makes sense. Or increasing the muscle tone around it so it allows it to
not be constantly being stretched
out.
on.
Yeah. Interesting.
I've kind of always thought that was like a general rule of thumb. If something is like weak or hurts, or there's like an issue, strengthening the surrounding area is like should be like one of the first things you do.
Yeah, but it's not applied, right?
The natural tendency is the opposite. The natural tendency, because if something's hurting, the body compensates for injury, and so there's a lot of redundancies, and so if you think about it in evolutionary sense, you've injured your knee, you still need to hunt and gather and to live, then you're going to move to the hip, and you're going to move to the hip until the knee injury's gotten better. If the knee injury never really gets better, like arthritis, then you just continue to move more and more into your hip to do activities. So you'll see people, the best example is Adrian, who was skiing, and skiing involves a lot of your thighs, but she had subconsciously, as her knee wore out more and more and more, the injury wasn't getting better, it was just gradually getting worse. She subconsciously shifted everything to her hip to continue doing that activity.
That makes so much sense. I'm like having just visions of clients I have,
right,
and just seeing like, oh, that now that all
That's
of
why they're
everything's
doing that.
like clicking.
yeah.
But it turns into a vicious cycle, because once you shut down the quad and the hamstring around the knee, now it hurts more, because now you're relying more on the static structures. So it hurts more, now you shift away from it more. And so then it also self-perpetuates.
And you would think that's and that's what physical therapy used to do. It used to address strengthening around those structures. And that's what I meant by it's not applied. That's not part of protocol anymore.
That's what I've noticed. Because like, when I was younger, my mom would go to physical therapy for stuff in like her neck and her back. And she said it would just hurt all the time. And nowadays, when she goes to like any sort of physical therapy, they don't do shit. No, they're just stretching her out, and like I can see the difference. My mom's gotten worse, and so
the back is the worst in terms of negligence that I've seen in my practice. And again, any therapist listening to this, it's not all therapists. Some therapists are absolutely great.
Yeah,
but at least in this community, when people say they go to therapy for their back, I ask them what exercises they're doing, and it's zero. They'll go through their entire routine and they do no exercises. As I sit down and I have this explanation, if you think about the pelvis, it's a extremely strong structure. It's a ring. It's inherently stable. You've got the long bones, which are thick and generally stable, and then you've got your rib cage, another ring structure, very, very stable inherently. And then in between your upper body and your lower body, there are these tiny, tiny little bones that are supposed to hold up your torso. And what really holds up your torso is all of the muscle complexes that extend from your rib cage down to your pelvis in 360 going all the way around. And then if you look at the back, I did research in anatomy of the spine, and the idea was, okay, what inserts where? Where's the origin of the muscle, where's the insertion of the muscle? And when you got into the spine, there were a million connections. It was basically the muscle was virtually matted into the spinal column. And so basically the muscles of your spine are your stability. As you age, those muscles marble with fat and atrophy away, and all of a sudden these tiny little bones, which were never meant to keep you upright, are now having to keep you upright, and they start moving abnormally against each other, and then that hurts. It causes back pain. And so inherently what you have to do to make the back pain go away is these massive muscle complexes that have gone away, you just need to strengthen them back up. It's basically put all the foundation beams back into your house. And when you do that, even if there's arthritis in the spine, now they're not moving anymore. And if they're not moving abnormally, then they don't hurt, and the back pain goes away. And that was explained to me by physiatrists my first year of residency, and then reinforced when I did the spine anatomy study or research that I did. And so the idea was, if you went to therapy, you got all of those columns starting, with the lumbar multifidus right at the spinous process going all the way around to the rectus abdominis. All of that was strengthened, and then your spine pain went away, your back pain went away. And if it didn't completely go away, it would at least decrease the amount of pain and decrease the episodes that are coming away. And I have yet to talk to anybody who went to spine therapy and actually did an exercise in the last 5 years.
Yeah. Yep. True. Because we get them in here,
Yeah.
and because they've finally given up on the traditional route of treatment for back pain, and so they're like, what do? Well, we strengthen your core.
Yeah.
And that core is not just the front, it's the back too, right? We strengthen all of that, and it's amazing. 3 months later, they're like, wow.
I talked to a guy last week that I had sent to, he asked me who you should go to therapy. This was a couple of years ago. I said, go to John Hodges.
Yeah.
And he was telling me the story. He had back pain on and off forever. And then he said he went to John Hodges and it blew his mind because John Hodges said, we're going to do deadlifts. And the guy was, what the hell are you talking about? We're doing deadlifts for hurt back? And he said his back pain's gone.
Yep. I have so much respect for John Hodges as a physical therapist.
Yeah.
He is amazing at giving people exercises to get better. It's pretty cool. We have a couple chiropractors that in the gym that work out of the gym, that the majority of how they practice is actually working with people with exercise and strengthening the structure of the muscle. And so they're obviously very successful in treating their patients, right? And the outcome is incredible. But it's simply back to the basics of getting people to move correctly.
Yeah. How do you rehab a back that's injured in lifting?
Well, it depends on the injury, right? I mean,
someone coming mechanical back pain. They say there's the back went out. They're lying flat on their back for 2 or 3 days. Sort of that classic back pain. I'm not talking about like they blew a disc and now they can't feel their leg.
Yeah,
I mean,
So we have a reverse hyper, and we have our reverse hyper set up onto an in the eccentric machine. And the eccentric reverse hyper movement is amazing because it opens it up and then it allows contraction, right? And so that's very successful. Regular hyperextensions, a lot of ab work. Usually if there's an injury, it's because something's weak in there. So if we can figure out where the weakness is, then we can typically make a big difference in the back pain and decrease the recovery time and prevent future injuries. And sometimes back pain or back injuries happen, right? Because you're doing a deadlift and you twist, or you move incorrectly. And
I've had those. I've had it where it's like I was laid out. I couldn't move for like 2 days. The very first thing I did was force myself to go to the gym in extreme pain.
Yeah.
And just fought through the pain and did reverse hypers. And it was like I had like pinched nerves, and like it was debilitating. And I was back to deadlifting within like 2 weeks.
Wow.
Because all I did was I knew if I just sat with it, it would just get worse. And so you basically just have to kind of grit your teeth and just pump blood into the surrounding area, strengthen it back up, and it tends to work. I had a lady, she had a bulged disc in her back, and like she showed me x-rays and stuff like that, and so worked on doing slow body weight reverse hypers, slow back extensions, because all she wanted to do was go back to squatting and deadlifting. A month later, she was squatting to depth and deadlifting with like no pain, and she was super excited about that. And it was just awesome. Like just building it up slowly. And I had her start doing deadlifts pretty early on, because I was like, if you we'll just start really light and just kind of build it up from there. And then once she got over the fear of like there being pain, and when she realized, oh, there's no more pain if I do this right, it just started like coming. And then she took a break from me for a while, but she saw me like a year later and got back with me. And then I asked her, I was like, "Did you have any more back pain?" She's like, "I haven't had back pain since."
That's awesome.
And
We also have a machine called Proteus, and there really aren't gyms that have it. It started in the baseball industry with famous, probably the best trainer ever for baseball, Eric Cressy. And so a lot of his protocols are built into that. So he dealt with a lot of people that were doing cross-rotational work, right? So he built those exercise profiles into the program, into the Proteus. And it's amazing how many people we have gotten change in back pain with using that, because everyone stays on that linear pattern, right? Planks, sit-ups, if they do sit-ups, but they don't do a lot of cross-rotational work. And so adding that in and giving the core that ability to increase the structure, that way as well, or the strength, makes a huge difference.
I think my favorite thing about it is it exposes the shit out of people.
Oh, the weakness,
yeah,
right?
because it shows like charts and like what side is weak and where you're weak at and like ratios and everything, and you'd be like, people are like surprised by like how much weaker one side is, and then then something like a light bulb goes off and they're like, no wonder this hurts.
Right.
Nice.
Yeah.
But yeah,
So we have so many more tools now than we did 5 years ago. I mean, it's enlightening or refreshing to see that there's more research put into keeping people healthy through movement and exercise.
It's sad that research is completely excluded from
medical
research.
And
it's good to hear that it's happening.
But it's not shared or it's not being accepted by the medical industry either.
I think we're more into the passive therapies, the injections, anything that involves engaging the patient to take care of themselves, we try and shy away from as much as humanly possible.
It's all about the quick fixes.
Yeah.
They don't work though. That's exactly it. I mean, like cortisone, it's a short time deal. I'm not saying cortisone's bad, but I'm saying it's not fixing the issue,
temporary.
right? It's temporary.
Yeah.
So.
I hear a lot too, people that take cortisone shots, it doesn't really do anything for them.
It's the only thing. If you look at the studies, totally blind against placebo, there are not a lot of shots that really have much of an effect.
Because I hear it all the time. Like, I just got a cortisone shot, and like they're still in like incredible pain.
Yeah.
It's so to some degree, cat's out of the bag. What it's doing is it's taking the inflammation down, but at some point, it doesn't matter what you do, it's gonna hurt. It's interesting. Been finding with American Iron, starting with you, Tammy, lifting heavy, going with a lot of weight, will push through cortisone.
Yeah.
If you can, it'll give you relief for your day-to-day activity, but you will flare up the inflammation if you're bone on bone if you start pushing in a lot of weight. And Travis found that with his shots.
Yeah.
You were the first to kind of notice that. Yeah, you felt better, but then when you went heavy, it was
gone.
Back, yeah.
And the effect was gone. It didn't after that, it didn't go back to helping with daily activity.
Yeah.
It just...
once it's inflamed, then
Yeah.
that's sad. I mean, the inflammation sticks around. But no, we've if you look at all the shots out there, the vast majority don't beat placebo, and the only one that did beat placebo was cortisone, specifically Kenalog. And not by too much. So,
not encouraging.
Yeah, and what that tells you is the injection's not. A fair amount of it's placebo, and some of it with cortisone works, and then all the other injections that are out there, probably what you're seeing. People swear by every injection that exists. Probably what you're seeing in almost all cases is placebo.
So that brings me to my next question. because you did some pretty extensive study or research in stem cell.
Mm-hmm. So there's a couple issues with stem cells. The body, when it's developing, it coordinates the creation of organs and tissues based off its relationship to other tissues. And so if starting from a single cell and then moving into multicellular and then starting to get more and more complicated, that relationship of one cell next to another, this one's expressing these cytokines, this one's expressing these chemicals, and that's what tells this one to become the tendon, this one to become the muscle tissue, this one to become articular cartilage. And the idea that you can find these stem cells, which are strategically placed in the body in association with other cells, and pull it out of that association, refine it down to give it exposure to chemicals to make it into, let's say, articular cartilage, the cartilage that's on the ends of your joints, and then just put it into you and hope that that cell now attaches itself in the appropriate manner to all the other cells and then starts growing appropriately, is fantasy at this point. Because you lose all those associations.
Yeah.
That's assuming that you get the cells that you want. You're no longer just putting it where it needs to be in association with the cells around it to do what it's supposed to do. So that's number one, and why they don't work. Number two, a lot of the times what you're asking it to do, let's say you take stem cells out of the fat tissue, which is a commonplace just because it's easy to harvest. Turning that into the tissue that you want it to turn into is exceedingly difficult. Turning it into that kind of tissue in any sort of volume is exceedingly difficult. The idea that you're going to find the stem cells, spin them down, and then put them straight back in without growing them is ridiculous. You do grow them in a lab, and then where are you putting them? You're going to inject them, and some people are mainlining the stem cells. And just the idea that this cell now is just going to float through the blood, find the part of the body that it needs to be in, attach itself, and repair that thing is ridiculous. It's not going to do that. It wasn't designed to be in the blood. It was designed to be next to the tissue it's supposed to repair. Yeah. Let's go to a knee. There's several layers of development of the cartilage cells. So the matrix that's your cartilage has several layers in it. Up to the surface, the cells in the surface are different than the cells in the middle, which are different than the cells that are attached to the bone. And then there's a special cellular layer, special layer that attaches cartilage to bone. Let's say you've worn all the way through your cartilage, which you do in several areas, patches in your knee. You've now worn out all the attachment layers. So you just now have a rock solid bone surface there. Now you inject a stem cell in there. It's not going to attach to the bone. It'll just get ground up as soon as it is in the knee or the hip or wherever you're putting that stem cell. So it's not, you need a way for it to attach, and it doesn't magically just attach to the area it's supposed to. Let's say that you're not all the way through the cartilage, that you're halfway through the cartilage. You're now taking a cell that is supposed to be at the bottom layer, right up against the bone, and it develops outward from the bone. Well, how is it supposed to get right up next to the bone if you've got a whole layer of cartilage there? So that's, on so many levels, we are so far from stem cells doing anything in your joint space that it's not a reality at this point. You can go back to the stem cells they're injecting. Let's say you get perfect stem cells, umbilical stem cells. Let's say you get them from fetuses, which is controversial, but let's say you harvest fetuses and do that. You still have the problem of it no longer has those associations with the cells next to it. And they're just injected. They're like, oh man, we got these great stem cells, and because they're so primitive that they can turn into anything. As cells start to work their way into developed tissue, the cells start to become more and more specialized. And you eventually get out to a point where this cell is only going to turn into fat or fibrocartilage, which is a cartilage that's used in repair of tissues. It's going to turn into one of these two things. You harvest that cell, and then you're going to try and put it into a different part of your body and hope that it turns into something that it's got to back up that whole evolution into something more primitive and then turn back into a tissue that's unrelated to those two things. It's not going to happen. In some cases, they can harvest stem cells, refine them, grow the tissue, actually get the tissue that they want, but now you've got to implant it somehow. And the times that I've seen stem cells work rarely is in young people where you can get a very primitive stem cell. We were getting it from bone marrow. And then we had to create a matrix that we could then put into a bone defect and then hope for the best, that it would somehow, if it was primitive enough, create a cellular matrix, and it was in a very isolated area that we had to protect with a membrane so that it didn't just rub off the first time you put weight on it. When you scuff up the bone, you can get development of something called the fibrocartilage, which is not articular cartilage. And so people were going back in and imaging and saying, look, there's this white stuff. It's not articular cartilage, it's fibrocartilage. But they were going, isn't this nice? Something grew.
So, okay. So question is that we want that cartilage there to protect the bone, right?
Yep.
Would that fibrocartilage be effective with that?
Not very.
Okay.
No.
All right.
So, and that's something called, you hear about where they'd go in arthroscopy and do these little holes in the bone to try and get it to bleed into the bone. Yeah. Microfracture is what it was called, and the hope was that it would turn into fibrocartilage, which every once in a while you'd get a fibrocartilage layer, and it was better than raw bone, but it certainly wasn't articular cartilage. So one of the issues we did find, my brother and I looked at modern day stem cells, what's going on with that, and the studies are god-awful. They're small, they're not very convincing. A lot of times they'd add them in with other things that, they were doing stem cells with orthovisc, hoping for the best. And we did find if you go into a knee that's has a lot of fluid in it, and you just pull the fluid off and don't put anything in, it feels great.
Well, yeah, it would.
So what they're doing is pulling the fluid off, and shoving the other stuff in, and be like,
yeah, it felt
my
great.
knee feels good.
It feels really good. Well, yeah, because you're...
Part of that, one of the formula that they had for stem cells, there was also one of the cytokines had an anti-inflammatory effect. So it's kind of like a cortisone. So people would feel better after their stem cell treatment, go, man, everything's better now.
How long
it was
did
an
it last?
anti-inflammatory. Well, if you can take them past what would have probably been a transient episode of pain anyways, and then it goes on for months that they're feeling good, a lot of pain just comes and goes.
Right. Oh, yeah.
And so, where a lot of people have made their living is making sure they do their treatment during that arc, and then they blame themselves for the pain going away, even when it would have gone away on its own. And those are the people that get the best effect from stem cells. They get a little bit of anti-inflammatory effect, so they say, oh, my knee feels great immediately, which makes no sense from the science of stem cells. If it's actually working the way it's supposed to, your knee wouldn't feel great immediately. It's got to grow, right? It's got to grow the cartilage. Oh, no, it felt great immediately, and then I felt great for a while. And problem is that pain probably would have gone away on its own. They got a little bit of anti-inflammatory effect from the injection, and $8,000 later, they want to believe it works.
I had more pain after the stem cell, not in the knee where they put the stem cell, but in the hip where they freaking took the bone marrow out of my hip.
That's hardcore.
Oh. That was brutal.
Getting a bone marrow for stem cells is going to be, that's an insanely painful thing to do.
It was very painful.
Yeah. Here was a fun fact. So I did harvesting stem cells out of bone marrow, and we were getting it from marrow for spine procedures, so they had to go in there anyways. And then I'd have to spin down the cells and identify stem cells. And after the age of about 50, there were none to be found.
Okay, so that was my question when I first decided to try that process was I have RA, I have osteoarthritis. Wouldn't those stem cells have all of that markers in it and how they're damaged stem cells if you can get any? So
the stem cells themselves aren't damaged. They're doing their best to try and regenerate whatever. RA is a immune response against your own cartilage, but it doesn't necessarily damage the stem cells.
Okay.
The big issue is you start to have a precipitous drop in the number of stem cells you have that you can obtain after the age of 25. And then by the time we got into, especially by 60, there might be one or two stragglers that you'd find, so oftentimes none. In smokers, you'd find no stem cells after the age of about 40.
Interesting.
So that's so what they're harvesting and putting in, we're not 100% sure what that is. They'll do the study on a 20-year-old, say, look, we found stem cells.
Right.
They're not necessarily including who they're using it for.
Yeah.
So, and a lot of those studies with stem cells are by the people who want to charge the $5,000 to $10,000 a treatment.
Seems like there's a lot of bias.
Huge.
It also seems like it's almost like a carnival game, like a ring toss, just injecting.
Mm-hmm.
You're just hoping something sticks.
Well, we've got a lot of baby boomers now with joint pain, and no one wants surgery, so it's turned into just a wild west of injections.
No one wants exercise either.
No one wants to do that one. and people who have done exercise and they're at the end of the road, they just don't want to. They don't want surgery, which is natural. They don't want surgery
because there's a recovery. You lose muscle, especially when you're in your 60s. You're like, damn, I've worked really hard for this muscle, and muscle goes away faster when you're old, and it's harder to come back.
100%. I had a hernia operation, and it was as someone who does a lot of operations, I get it. By the time I had mine done, the surgeon, first thing he said was, "You let that go way too hard." I'm just as guilty there.
Yeah. I get it. But there's also that, and that's what I was telling the young lady I introduced you to today, was that, look, you're doing more damage. There's that critical point, right?
Mm-hmm.
You're doing more damage by not having this stuff.
Yeah.
Because you're compensating. So you're hurting your back, you're hurting your knee. She was even hurting her shoulder the way she was benching.
You were talking so much shit.
Tammy has a motivation style.
I come back and I'm like walking in the office and I can hear you from this room in the shop just talking about that look like shit.
Well, it did. She's a world-class bench presser. She's an amazing little athlete, right? I'm like, man, girl.
To be fair, I did catch one of her benches at Bench Worlds.
Yes, you did.
Failed.
Yes, you did. She remembered you because of that.
Because I remember that too. Because Tony and I just looked at each other because we heard her scream and we're both like, did they hit her face? And then we went back and watched the video and we're like, oh no, it didn't.
No, she was just pissed.
Yeah.
She was pissed. The scream was because she was mad.
Well, here's a question for you, because sometimes patients are just going to do their own thing. They don't want a trainer. And so I'm sitting there counseling them on sort of the process and evolution. I'd love your take on this. Injured, post-op, whatever, it's the limb is down and out for one reason or another. I generally, and again, you can tell me if I'm wrong, I generally tell them the big dynamic movements that involve just your entire body, deadlifts, squats, to stay away from those until you're completely back up to normal with the more individualized workouts for the injury.
Absolutely.
So I don't know when you start that stuff.
Well, otherwise they're going to hurt themselves, right? If they're not activating their glutes and they do a squat, that tibial plateau is going to go way over the knee, and they're going to cause more stress on that joint structure. I mean, so
A lot of people don't realize that they're even doing it.
Yeah.
Most people can't recognize what they feel in their body, whether someone's activating or not.
Yeah.
So you're right. You want to stay away from those loading, major.
Do you start them light?
Yes.
Before they're fully recovered from the
Absolutely.
injury?
Well, and this was the best thing about all the injuries.
Not you start yourself light. I'm talking about if you're giving advice to someone else.
Well, I started myself light. Even. So that was the best thing about these injuries is I have a lot of personal sense of what it felt like to be able to share. And one of the best things ever was utilizing the earthquake bar because it made me squat correctly. Otherwise, I'd land on my ass. Stability. So it makes you, the earthquake bar makes you do something that we call rooting. And rooting is pretending you're a giant bird, right? Birds of prey, giant birds do not start their flight from their wings. They start their flight from the power of their legs. And you do that by engaging your big toe, which is your big talon, little toe, which is your little talon, and your heel talon. And by thinking about that and rooting, you're actually focusing on the medial aspect of your quad, lateral aspect, and your glutes. And if you have someone stand and go, okay, grab the ground with your heel talon, their butt will tighten up, and they'll actually get that glute activation. So we start there, and then we start teaching them simply how to brace. Because if they're not bracing, they're loose in their core, they're going to hurt their back.
I think that's one of the hardest ones.
It's teaching someone to brace.
Because most people, they want to pull all the air into their upper body rather than their abs.
Mm-hmm.
And when you do that, you're loosening your core even more. It seems like you're still getting air, but now you have nothing protecting you down here. And like the idea of like the 360 expansion.
Yeah.
I think that's a big one. Is like trying to get people to learn how to do a 360 expansion, because then you have the whole trunk build up, versus not doing that, then you're going to be moving all over the place, causing more problems, especially with the earthquake bar.
Well, honestly, that's one of the things with earthquake bar is you can't squat without stabilizing your core and rooting correctly, right? You can't stabilize. So using that very lightweight and just working range of motion up and down is a wonderful tool. So if they want to squat and do activities of daily living, like simply getting into a good position, using that technique of rooting and bracing and sitting into a chair and standing back up.
Yeah.
So as far as squats, we'll start there.
Mm-hmm.
Even
with a little bit of recovery.
Mm-hmm.
So you don't wait till they're totally...
Absolutely not.
Okay.
No.
You don't go heavy until...
Exactly.
Gotcha.
The earthquake bar, you just can't go heavy at all.
Yeah,
Because
so
you're just
there's-
going to crumble. Like,
Yeah, and what's nice about that is there isn't a lot of load on the spine, right? Because it's light.
Mhm.
So
It's
it's
a
more just
3 pound.
stabilizing.
The bar is 3 pounds.
But then when you put the bands and the kettlebells, maybe 20 pounds, maybe 30 pounds is all you're loading.
I remember.
I wonder if you remember that. So I think it's really important to integrate activities of daily living with people, which means reaching down to the ground, picking something up, right? Sitting into a chair. At the same time of working on isolation. You're only as strong as your weakest link. So you still have to work. And I know this was a big thing for a long time with orthopedists, never do extensions. And we had that talk, and you're like, no.
Yeah.
So, doing extensions, doing leg curls, getting the activation of the muscles themselves, and then doing those full body movements light.
I think that was, back in the days of surgeries where people would just lie in the hospital for 2 weeks, and then we wouldn't get them up walking until the pain was gone. That was before my era. We were down to 2 or 3 days in the hospital when I got into town 12 years ago. But it was, the mentality is completely shifted, and it used to be, if it hurts, don't do it. And that was very much and we've gotten better in the medical world of saying, go, move, be active, we've gotten horrible at telling them how to do that.
Right.
We say, go do it, but then if they say, hey, this hurts, then we say, don't do that. Be active. Well, we know walking is going to hurt, but we want you to walk. Well, how about this exercise, like in back extension? Well, does it hurt? No. Or yes, don't do that. Yeah, well, that's what I'm saying. It's like they'll come back and they'll say a specific thing hurts. Well, don't do that then.
Right.
Which is going counter to the whole movement and then the strengthening aspect.
Right.
It's like we talked about that also with the open chain, knee extensions.
I think too, people, when it comes to pain tolerance, people don't know really what pain is. And so they have a slight uncomfortability and they call it pain. Does that make sense?
Oh yeah. Yes. Or they feel they just won't tolerate pain. Like the notion of pain tolerance. This was with the opioid crisis. The mentality was no pain is acceptable. And so that's literally what led to millions and millions of people being hooked on opioids.
Yeah. Makes sense.
It's such a horrible mentality.
But I would have to assume that the patients that have their athletes have a lot higher pain tolerance than the people that are not athletic.
Yes. Well, especially coming from your gym. I think they might have been conditioned by someone, though.
Yeah. No whining. But I would think that because lifting, doing athletics hurts.
Yeah.
I mean, it doesn't. It doesn't always feel good, right? It can be painful, and it's not hurting you, but
they tolerate it much better. But I mean, again, with regards to what was acceptable pain, back in the day, if your knee was too stiff, and still to this day, if your knee is too stiff, we would do something called manipulation. And basically, you're trying to break through the scar tissue for 6 weeks, and in a manipulation, we take you back, we put you to sleep, and we just
force it.
Nutcracker.
Yeah, and that's what you did to my knee.
Yeah.
Yeah.
That's if you have a block or whatever it is. They used to, before we don't tolerate any amount of pain, they used to do that in clinic. You'd show up in clinic, you were tight, they needed to manipulate. I remember reading accounts and talking to old timers. They would take that shoulder and just rip it out and break through the scar tissue. Or they'd just push through and the scream would be all the way through the clinic, but they'd get through it, and that was okay to do. Nowadays, no pain is acceptable. Yeah, you can get sued for doing something like that. It's kind of gone to this whole mentality of no one can be uncomfortable, no one can be in pain. So
I think that would make your job a lot harder.
Yeah, I mean, I never really had that. I tell people to go hurt themselves. So, and then reprimand them if they're not.
Right.
But it's definitely professional.
To,
Yeah. That's been it's shifting back a little bit. Man, 10 years ago, at the height of the opioid crisis, we would just load people up until they were passing out or not breathing, because anything less than that was unacceptable.
I remember calling you with the knee up to the knee replacement because that
hurts like hell.
Yeah, it did hurt.
But and yours was special. Let's just so the listeners know. We see this in surgery in general. There is something about the level of inflammation and pain that happens in the context of a break. So people are
there.
Yeah. You had a plateau fracture. And so when we've seen this with hip replacements, because we'll do hip replacements for femoral neck fractures, someone comes in, they broke their hip, you do a hip replacement, they hurt more after that surgery. Same surgery. The same protocols. They hurt way more afterwards. Something about that inflammation just getting out of control with the break. So you were in a special circumstance there where you had a tibial plateau fracture, which is not what we typically do knee replacements for. You had underlying arthritis, the fracture was very superficial, there was no way to fix it, so knee replacement was what we were going to do, but we don't typically see that where the broken bone compels us into surgery. So you're in what is generally considered an extremely painful operation. a special snowflake in that you also had the break on top of that. So, sorry, I cut you off.
No, but
there was a lot of pain.
There was a lot of pain, and I know I had called you and go, man, I can't, what do I do here? And you told me to do the combination of the Advil and the Tylenol because the pain meds weren't doing shit.
Yeah.
They really weren't. That was a game changer.
Yeah.
That, staying with the ice, using the sleeves and the Tylenol, and not doing any of the opiates or the pain meds and the Advil, that, I was like, okay, I can do this.
Nothing addresses musculoskeletal pain better than anti-inflammatories.
Well, aren't opioids? They're just flooding your brain with. There's no actual like pain relief. It's just
no, there wasn't.
It makes you you get high enough to feel like it doesn't matter.
Yeah,
and so that's basically how those work.
Yeah, it's horrible.
And the I see that all the time. The anti-inflammatories cut the pain, and people go, well, that's just to make the inflammation go away.
Well, yeah.
And they think the Tylenol is for the pain and the ibuprofen is for the inflammation, and the ibuprofen is infinitely better for pain, and taking inflammation away takes pain away. It's inflammation causes it.
I rarely take ibuprofen, but like the one time a year I have to take it because I hurt myself. It definitely it's like a game changer, and I don't take a lot, and I can definitely feel the difference every single time.
Yeah. No, it's incredible. That's it's the best drug we have for pain, I think.
I will attest to that.
Yeah.
You know, personally, that was the thing that, okay, I can move now. I can function. So, yeah.
Yeah, I have a lot of people can get by just on that with hips. Knees, a little more rare.
Well, actually,
knees generally need a little extra, but in your case, that was the one.
That was the one.
Yeah.
That's what worked.
Well, part of it too is, I mean, how much do you take ibuprofen in general?
Not a lot. I try to stay away.
Yeah.
No. I try to stay away from it.
And that's why it works so well.
Maybe on a heavy day, I'll free dose.
And a lot of patients are coming in on steady doses of anti-inflammatories, so it doesn't work as well for them afterwards, because the body just clears it gets into a mode of clearing that and tolerating it and building up a tolerance to it, like any other drug.
Sure.
And so if you want the anti-inflammatories to be really effective, don't take them very often, and then they're incredible.
So, what's your thought on peptides? On some of the peptides that are being used in injury and
the
like the BPC 157 and TPE 500. I know you said injectables are not, they're placebo majority of the time.
Well, so peptides are, anytime you're trying to basically go into the process in your body, go beyond what your body does a pretty good job of regulating things, and if it needs to repair, it does a good job of repairing, and knowing how much of what natural peptide needs to be part of that process. You get into adding to that process, basically tricking the body to go into hyperdrive for that. There's a lot of questions still with the studies. And that's the issue.
Yeah.
Anytime you hyperdrive something beyond what's physiological, then you have to worry about the risk profiles. And that's where things get ugly. Yeah,
and there isn't a lot of legitimate studies yet.
Most cancer, basically cancer starts 20 years before it presents in a lot of cases. So that's the scary part.
Yeah.
The long-term repercussions of telling a part of your body to go into hyperdrive, creation of tissue, creation of cells, we won't really feel till later.
Interesting.
And where that process was sped up in small animals, I remember there was a study that showed a lot of tumor production.
Yep.
I'm trying to remember which peptide that was.
Osterone, I think.
Yeah, it wasn't. Isn't ostarine a...
It's a SARM.
It's a SARM.
Yeah,
It's
it's
not
not
a
a peptide.
peptide.
It kind of goes into that same category, though.
Yeah,
It's just not studied, and it's trying to get your body to do something on overdrive. So, do they work? I don't know. Do we have the big studies that show that they work? No, we have more anecdotal evidence than small studies. Is it mildly terrifying in terms of what the long-term repercussions are? Yeah.
Especially for someone who's done a lot of research. I mean, you're not only a practicing orthopedic surgeon, physician, you've also spent a lot of time with research.
Take a look at OrthoVisc. That's a good example. There were small studies that showed it knocked it out of the park. And then there were big studies that showed it knocked it out of the park. And then there was the Cochrane database, a big conglomeration of all the big studies out there that showed it was worthless. Take a look at BMP. We were putting it into spine surgeries, 10 grand a dose.
Yeah.
And then when the whistleblower law came out, they said, hey, by the way, we faked all these studies. And they were perfect studies. They hit on every cylinder, everything you could ever want. And then the guy I'm a little shaky on the details, but I think it was one of the people responsible for the studies, because the whistleblower law came out and protected a lot of the turds that actually created the problem, came out, blew the whistle, and then got huge financial compensation. So on one hand, it was nice to hear him blow the whistle. On the other hand, these were the assholes that should go down for this.
Right, yeah.
And so, that's the terrifying thing about studies. If you just see one good study,
Yeah.
it could be that BMP situation.
Yeah.
How many skeptical people that don't have a desire for a particular outcome have actually done the study? A good example of this is, and this is well-meaning studies that might not be good. Just give an example of saunas. If you look at all the benefits of saunas, the studies are ridiculous. You would think you should be in a sauna every day, and you start when you're a kid. It's amazing. Then you look at the names of all the studiers, and it's Bjork, and these are all Finns who their entire lifestyle revolves around saunas. It's part of their culture.
Right.
I would love to see a Garcia, someone from Spain, where saunas are miserable, where it's hot every day, and why would you get into a sauna? Do that study with some level of skepticism. And if that guy who says, I went into this study not wanting this outcome, and I've showed that it actually has a lot of benefits, how many people are compelled to do studies like that? How many studies were there of people who weren't Finns that was part of their culture? They wanted a certain outcome for this. So even though it's a well-designed study and it's somewhat convincing, now you're getting into this world of, well, okay. So who are the people doing the studies on the peptides? Are these well-meaning, neutral people, or are these people that want the peptide to work?
Most of the studies that I have accessed and read were people that wanted a positive outcome from them. I mean, they had a vested interest in the peptides working.
So that's, and again, they might work.
But like you said, they do work.
Yeah.
I experimented with the BPC and the TB when I couldn't get rid of this inflammation in this knee. And within 72 hours, there's a significant difference in pain and inflammation. But there are no long-term studies. So I have no clue what the outcome of that's going to be in 5 years, 10 years, 20 years, right?
Yeah. So that's the problem with them. And they might be everything we hope they are.
Yeah.
But and it's interesting. I was going to look back into this because I'm hearing a lot more about them. I get people asking me about them.
Mm-hmm.
So I actually had every intention of doing a deep dive into peptides and really trying to suss out what's good and what's not.
I would love to see what you come up with and talk about that, because the effect on that knee was significant.
Yeah.
And it wasn't just, maybe it was just the inflammation that affected the pain, but I had probably a 50% reduction in 72 hours of pain and inflammation. It was
awesome.
Significant.
So, and again, it would be nice to see more studies done on that.
More legitimate studies, people like you said that don't have a vested interest, that are skeptics, right? But we're going to have to. There's going to be a time trial too, because we don't know long-term effects of it. That's just going to have to,
do a retrospective on people that have been using them, and then see if they add more of something or another. But again, when you start trying to create abnormal levels in the body of anything, that's give me the safety study first, and then if it shows that it's safe, then I'll entertain the benefits.
Yeah. See, we need more people that know how to do a study, or know how to read a study and evaluate it too.
Yeah.
And you brought some things to my attention that I never would have recognized when we were talking about some other studies in the past. I'm like, oh shit. So it's, they can make a layperson, they can guide our emotion or our feeling about that study any way they want and how they word it. Where someone like you're going to come in and you're going to look at it from a very analytical, skeptical standpoint and be able to pick that out.
We had, I remember seeing the physical therapists were taking a shot at a study, and they were trying to claim that copper, which is one of the bigger snake oil things out there. Basically, anything you put on top of your skin is ridiculous. The skin is an incredible barrier.
Yeah.
It keeps everything out. It is, if it were to actually let things in any appreciable amount, then we'd all be dead immediately.
Die of MRSA.
Right,
immediately.
Not just bugs, but chemicals.
Yeah.
And so people are constantly putting stuff on creams and all kinds of stuff, and you go, it's all, most of that, almost all that's placebo. But a good example of a study was they were trying to show that copper helped carpal tunnel syndrome, and they were putting copper discs right over the wrist, right over the carpal tunnel, which is right where you bend your wrist. And they were putting bigger and bigger pieces of copper, strapping it to the wrist,
which limited the
movement of the wrist.
Yeah.
And you could show that study and have all these incredible outcomes, but then you basically were splinting the wrist. And the more copper, the better the outcome. Well, the more copper, the more you're splinting the wrist. So it was, that's a good example of one of the things that happened in med school and then in residency and in fellowship is we would do journal clubs and conferences, and we would basically, the entire gist of that, and this has been part of the scientific process for a couple hundred years, is you would get the study and then you would pick it to pieces. And that was the goal, was to pick the study to pieces. And no one was happy with a study you couldn't pick to pieces. It would almost send everyone into a frenzy. And then you would start making up stupid stuff as a reason why the study didn't work, because you couldn't have a study that was perfect. There's no such thing as that.
True.
And so what we did was we picked these studies to pieces, and that process became ridiculous. But it also refined research.
But what a cool educational,
I mean, part of it was to be you into when you left, you could then look at a study and go, this is BS or not.
Yeah.
But a lot of other fields out there that didn't go through that process of beating each other up over studies have decided, because research is this gold standard for saying truth, they've now decided to take it upon themselves to do research, but they didn't go through that process of beating each other up over what's a good study or what's not. And so you're starting to see a lot of, and I'm sure there's good researchers out there. I'm going to temporize this and not say everyone in this field, but say for nutritionists, physical therapists, nurses, people who didn't go through this process are now doing studies, and they don't have that. And then we live in this kind society now too, where you're not allowed to give each other criticism. and so it's basically just wiped out the quality control of a lot of studies that you read out there.
That's why one of the biggest things I see is nutrition studies. everything is like dissenting information.
Yes.
There will be one study that says one thing and the one that just refutes the complete opposite. And I've hit the point where I just think it's all bullshit.
It's hard not to get jaded. I've looked at the nutrition stuff too, and there was I loved it. There was a study that came out that was looking at all the other studies for testosterone production, what will increase testosterone production in someone. And they had a list of supplements. And they next to each supplement they had how many studies there were. And I think in the case of zinc there are 171 studies that they'd identified. And then what percentage of the studies were for, what percentage were against. And
We need more databases like that.
It was awesome, and it just showed you just all of the and how much conflicting evidence there was just in one subject matter. Yeah.
Interesting. So if you could have the ideal scenario for a hip or a knee replacement with a patient, what would that look like? I mean, obviously someone that doesn't have an injury coming in, but you have the ability to craft the whole process.
The prehab we've shown, you guys have shown probably more than anybody how incredibly useful that is. Because you put it to the test with your powerlifters, going into it, you're exercising, you're getting everything teed up, because one of the things that we've shown is there's a significant atrophy of muscles after surgery. Mm-hmm. And to some degree, there was a great study actually that came out that actually looked at muscle recruitment, let's say for a total knee, and they showed a 60% decrease in muscle recruitment. So you're only using 40% of your muscle fibers even up to a month after. And we've shown significant atrophy sets in 2 weeks. And then slowly over time that muscle recruitment comes, and it's variable. Some people had incredible muscle recruitment, others didn't have hardly any at all, or almost complete shutdown of the muscle for a month. So prehab. Prehab in the hip especially, a lot of stretching beforehand. Yeah. I'm all right with some lifting. I don't necessarily want people to just go for broke in a hip because exposure becomes an issue. I don't want them atrophied away, but I also at the same time I don't want them peaked out, with their muscle development in the hip.
I had a late surgery. It was a 4 p.m. surgery. So I decided that I really wanted to get a dead and a heavy leg workout in. I did a maximal deadlift workout and a maximal leg squat workout
now you tell
before.
Me. Now you tell me.
That seems...
It was...
I can't believe your thought process.
We had her totally paralyzed, and it was so hard to move her muscles. They were so tight. Yeah.
You put a lot of faith
into
him when you did that.
I have absolute faith in him. Absolute.
So prehab is good for a knee. So in a knee replacement, go for it. I want you to push as hard as you can. I want you to get your hamstring or quad as strong as you can get it going into the knee replacement. For a hip replacement, light workout just so you don't lose your muscle tone, but a lot of stretching.
More stretching, more mobility.
Yeah. So that would be perfect going into those. Surgery goes, and then for the hip, probably doing the compression sleeves. Starting, I gave him your protocol actually, the one that you told me you did, which it turns out it wasn't quite what you did. You were more aggressive than this, but I tell other people this is this is the way to go. Start on a bike in about 10 days, and then you can start lifting legs at a month and get back into what you want to do. More tailored approach. The athletes would love them to start working their glute and concentrate more on the posterior chain, because people will focus on the hip flexing, but they won't focus on the posterior chain, and that's where you can get the psoas tendonitis. That would be the perfect rendition for the hip. For the knee, this is something I'm kind of sussing out right now. What point to hand the knee off to the lifters. We have the incision on top, but there's an incision underneath which does run up the quad tendon. So what I don't want people doing is pushing too hard into their quad strength, because I don't want them ripping apart that incision, trying to fire up the VMO and then have the VMO actually tear its portion of the quad away.
Yeah, that'd be.
So that's why I restrict that for 6 weeks. I don't want people really lifting, isolating heavy quad exercises. Little ones are fine, but heavy quad exercises, I don't want anyone to start into that for 6 weeks. So the focus is on range of motion, whatever exercises they can tolerate. I'm not as concerned about exercise in the first 6 because the focus should be range. And then you can start to exercise your hamstrings because that's not going to mess up the quad repair. But once that capsule's healed up in about 6 weeks, you can slowly start to work your way back up into the quad, and really exercise. And what I tell people, because there are people that aren't going to make exercise their lifestyle.
Right.
So what I tell people who are profoundly weak, either before surgery, after surgery, 2 years out from surgery, is you need to exercise until you can go down a steep hill or down the stairs normally with no discomfort. And when you can do that, then you don't have to keep lifting if you don't want to. I tell everyone to keep lifting. It's a fountain of youth. But
It is.
if you're not going to do that, at least keep exercising until you can go down a steep hill.
And I think what people don't realize is they don't have to go to a gym for any of this. I mean, all of what you've lined out can be done at home.
Yeah.
You know, bands are amazing tools. So get with someone that knows what they're doing, that can help them do it correctly, and then just, take half hour a day, and I think their outcome would be so much different.
One of the things that I love about gyms is that it creates a level of accountability.
Yeah, it does that.
Either if you're with a trainer, that's obviously the best. If you're not with a trainer, at the very least, you've set aside the time. You've guilted yourself into at least spending some time there. To just show up at a gym and leave 5 minutes later. Not a lot of people will do that.
Right.
And so they'll actually put in the time at the gym, as opposed to home. You turn on a movie, you're having a snack, you're a little bit tired, there's no one holding you accountable.
Yeah.
You can do these things at home, and if people just aren't going to go to a gym or a trainer or anything like that, then obviously, yes, do them at home and
do something.
Routine with
versus
bands,
nothing.
yeah. And I will encourage them, and I'll tell them, do this, but...
And a bike.
The bike is one
Huge.
that they will all do, yeah. Well, as much as anyone will do.
Yeah.
Bike is good, but it really would be nice, and I tell people, just get the gym membership just for a little while.
Yeah, even if you just get it for a month,
Yeah.
It's $50 for a month. And there's so much knowledge here.
Yeah.
And it's such a community that if they, members see someone else struggling or not understanding or not, they'll be right there helping them to learn how to use the machine, or to help them to figure out what other exercises that they need.
Yeah.
There's just a lot of knowledge in that gym, and that's cool.
And even outside of, your gym, I'd send everyone there, but even outside of a gym, we are now at a point where personal trainers, your generic personal trainer, and obviously it's a whole different breed at your gym, but even a generic one with just generic training and generic thought process is infinitely better than your generic physical therapist now for strengthening.
Absolutely.
So,
and people say, well, my insurance covers the physical therapy. Well, you know what? You could almost pay for a personal trainer with your copay.
Way more. Yeah.
So,
copays are so big now that a lot of times it's cheaper.
Yeah. And your outcome's going to be better.
Yeah.
With that, trainer.
If someone isn't going to work out, they're not going to do the bands, and they've had a knee replacement, I tell them and they're struggling, I tell them to find hills. Yeah. Because you can lock your knees out and walk almost without a limp, without engaging any of your quad and hamstring. which is what you need for knee recovery. So people that just walk and are still having problems, which is not a small number, I say you got to find stairs, hills. I'd always recommend a bike. If you're not going to do the bands, if you're not going to do anything else, at least find some inclines and declines where you start to engage your thighs.
Yep. UNR Stadium.
Yes, I've had a few.
Yeah.
I've had a few, not just,
Yep.
I've had a few people go do those stairs.
Yep.
Yeah, that's a good one.
Put a weight vest on and
Go for it.
run the stairs.
None of them wore weight vests.
Oh.
No.
Just an
But
idea.
they all did, yeah. Well, I think one did. But,
Yeah.
none of the others. But, just even the process of doing stairs is so much better for the leg, for knees.
Yes, for knees, yeah.
Yeah.
It's very helpful.
Yeah.
It starts to help with that mobility. And the thing that I found and I saw in a lot of other patients was not just the bend, but the forward angulation of the tibia for whatever reason.
Forward angulation when they're...
when your knee's moving forward.
Yeah.
Like, and I said when you're using your foot straps in on a windsurfer, right?
Mm-hmm.
You have to have a lot of forward angulation to get the tuck
Tuck it
under
up.
you.
Yeah.
And that was what was limited for a while.
Yeah.
I mean, it could bend, it could be at 90 degrees, but then when I moved that whole tibia forward, that was the limiting factor, and that seems to be with other knee replacements as well.
Yeah. And really it's engaging those hamstrings to get that, to get bend. And, if you're curling up onto a windsurfer, that's all
Yeah,
hamstring.
you're doing it. Yeah, you are. Yeah.
Does that go back to like the hinge idea?
One of the things we found really pushing into this is that probably the biggest hit to the leg after the knee is the hamstrings. Both with arthritis, the hamstrings just go away, and then after the surgery, hamstrings take a huge hit. And so people will come in and they'll have some quad, but when then you have them bend their knee, they have no resistance. The hamstring is just gone. It's never really engaged and shut off.
I feel like, now this is just like a personal idea. I don't know how true it is. I feel like basically almost everybody does too much quad work and like not enough hamstring work.
Okay. Look at the gym. Watch the gym. The leg room. How many open hamstring machines do we have consistently versus how many open quad machines do we have? I'm always friggin' waiting for one of the quad machines. I can get a hamstring machine anytime I want.
My clients are always asking me, they're like, why don't you give me more quad? And I'm like, because you don't need it.
When I went into the knee surgery, my hamstrings have always been stronger than my quads. So what I lifted on hamstring movements was significantly more than what I was doing on quads because of that knee was jacked.
Yeah.
Even before the fracture.
Yes, it was.
And afterwards, my quad was significantly stronger than my hamstring, and it took a little more than 6 months to get that hamstring back to where I had the strength that I had before.
Yeah.
So it wasn't a slow, quick process.
Yeah. To some degree, what you can do if you're going upstairs is you put your foot there and then throw your weight forward rather than curl that stair toward you with your hamstrings.
Interesting. Okay.
So you can compensate a lot for your hamstrings just by throwing your weight forward. Versus now your weight's forward and you have to get up. You can't. You still have to use your quad.
Right.
So inclines are like that. Stairs are like that, where you can just flip over the top of it and then quad your way up.
Yeah.
So there's a lot of ways to just not use your hams.
There is, and we see that consistently when we're working with people in the gym and we're having them do step-ups, as we have to keep it lower because they cannot stay erect and do that compensation initially.
I can see that.
And so until they can correctly step up without hinging So that's the nice thing about that is you can keep it lower until they're good there, and then you bring it up and keep increasing until they're able to consistently utilize that hamstring to step up.
To pull it.
Mm-hmm.
Yeah.
Stuff.
It's like such a huge thing that I see.
Yeah.
Jeremy brought up a good point when I first started working here. I was talking to him about it. He was talking about how in our daily life we use our quads virtually for everything, and we don't really use our hamstrings for very much. Because he was like talking about just driving a car, and now I notice everybody's right hip will tend to cock out a little bit farther
on their squats.
Yeah, or
Uh-huh.
just even walking.
Yeah.
Because, you press the gas, you're usually not pressing the gas with a straight foot. You're kind of getting lackadaisical.
That's why everyone should drive a clutch. Just saying.
That makes me wonder, do you see more in the right hip or the left hip?
I've never analyzed that. That's a very good question.
Because if I had to take a guess, it would be the right hip.
Yeah. Yeah, I could look that up sometime. I'm kind of curious, actually.
That'd be interesting to see. Yeah.
And because I notice most everybody, there's something with the right hip.
Yeah.
And so I'm just very curious if that is just way more common than left. And I think that just has to do with like daily life.
Yeah, could be.
I'd be curious to put it right-handers versus left-handers too.
Yeah.
Yeah.
See how much of, you lead with the right, you feel more comfortable on the right just because you're right-centric with a right-handed person, if that matters.
Another idea, because I think it's military, they lead with their left foot. You can always tell someone's military because they will lead with their left foot.
Really?
That's what they're taught. They're taught to always lead with the left foot. So every step, when they step off of something, they'll step off with their left foot. So I wonder if there's a correlation
might
with
put a kind of a deviation in the study of right and left-handed.
Yeah, so we'll cut out the military people.
You can't play in our study.
No, that's not.
You're skewing the results,
you're
man.
A confounder.
Well, Jackson, I got to tell you, thank you, man. You have kept our people functioning and getting back into their game and having a successful life, right? So
I'd have to say a bigger thank you because we're kind of changing the way we think about rehab and the post-operative course because of you guys.
You are. You are.
This was
there's no we.
This was me taking this problem, going, "Hey, Tammy, can you solve this?"
But you are so growth-minded, and that's not typical in the medical industry, especially with physicians. They tend to get very stuck in their box in the protocol because this is what I learned, so this is the way it is. It's the only way it is. Where you have that open mind and that you constantly want to learn and grow. So you're like, hey, we need to make this better. How can we do that? Right. So
it's helpful, but again, there's a lot of stuff. I did not pick up on hamstrings until I started sending people to you guys. And then it was wait a minute. Now I tested in everyone who comes in with knee pain. That's had a total knee.
And hips too.
And hips with the glute. I mean, I identified a problem and then presented it to you guys, and you said, no, there's no hamstring here. There's no glute here. That stuff I had no idea until you guys told me. I certainly wasn't learning it in medicine. Yeah. I mean, you think, doing it for a profession and everyone talk, I mean, we talk all day long about implants and never about the important stuff
structure
that's
around the
that
implant.
joint. All that important stuff.
It's really not that different from a car, right? In a mechanical joint.
Yeah.
If you have something that's over tight on one side and pulling that joint's gonna that mechanical joint's gonna wear out. It's not gonna function. It's gonna have limited range, right?
Yeah.
And it's the same with the body. If you have all this tightness in the anterior aspect to that hip, and nothing going on in the back to stabilize that back.
Yeah.
It's
You're going to inflame the hell out of it.
yeah.
Yeah.
So
No, that's been really nice. Been a whole game changer for the practice. Hopefully, start talking about maybe moving it into a little bit more of a recognition of that. Studies, trying to get it out there. I've been talking a lot with my partners, but maybe even push it out into the more national level. So I think that's the next step.
that would be good. I mean, but there's still docs that are doing hip replacements from posterior, and cutting through that glute.
I mean,
There-
there's a lot of methods that don't disappear until people retire.
It's pretty scary.
Yeah.
So once again, thank you.
Well, thank
really
you.
Appreciate
Yeah.
what you've done for our members.
It's gone both ways. It's been really fun.
Yeah, it has been fun.
Yeah.
It's been fun. And we have a lot of guinea pigs to practice on.
Absolutely. That's the best part.
willing
We can find the
guinea
limits.
pigs,
Yes.
Just give me a few more
Look at
years.
the
I'll get there.
All right.
All right. Good?
Yeah, that was
Freaking
2 hours.